Welcome to the Beyond 50%, leveraging a team-based care model to diagnose and treat hypertension conference call. My name is Danielle, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Ashley Green. Ashley, you may begin.
All right, thanks, Danielle, and good afternoon, everyone. I'm Ashley Green. I'm a Quality Improvement Project Specialist with Lake Superior Quality Innovation Network. I'm actually in Madison, Wisconsin with Metastar, one of the three participating QIOs, along with Stratus Health in Minnesota and IMPRO in Michigan. And I'm very happy that all of you could join us today on our webinar. Before I introduce Gina, just a couple of quick housekeeping things. So the call, or rather your lines will be muted, but we will open up the lines at several points to take questions. If you don't want to phone in a question, I'd like to encourage you to use the chat or the Q&A boxes on the WebEx. We'll monitor that along the way. And we'll have a final Q&A period towards the end. So feel free to put those questions up whenever the Spirit seizes you. So with that, it's my pleasure to introduce Gina Dennick-Champion, our presenter today. And of course, she has a resume that is difficult to summarize, but I'll try my best here. Gina Dennick-Champion is the Chief Executive Officer of the Wisconsin Nurses Association, and her responsibility is to promote the mission and goals of the WNA, which support and promote the important role of the registered nurse as a patient, advocate, and collaborative leader in the delivery of safe, quality, cost-effective, and innovative care throughout our healthcare system. Gina represents the WNA on a variety of state agency and association advisory councils that include nursing, other healthcare providers, and healthcare consumers. Gina is also Wisconsin's only nurse lobbyist. She advocates for the advancement, promotion, and protection of nursing practice, which in turn supports a healthy Wisconsin. She's also the project director for the state of Wisconsin Department of Health Services Division of Public Health, the CDC Chronic Disease Prevention Grant, whose purpose is to identify and offer a model of patient-centered team-based care within Wisconsin's primary care system, and we're going to hear about that today. She's a frequent presenter, guest lecturer for schools of nursing, and serves as a preceptor for undergrad and graduate level nursing students. She holds a Bachelor of Science degree in nursing and Master's degree in nursing, with emphasis in community health gerontology from the UW-Milwaukee, and a second master's degree in healthcare administration from Cardinal Stritch University. Gina, thank you so much for being with us today.
Well, good afternoon, everyone, and thank you for joining today's call. I want to start with, it's been a wonderful opportunity to work with Ashley and Metastar on all of these projects in terms of patient-centered team-based care and in terms of what we're trying to do to address the chronic disease of hypertension. So with that, I will be pausing. There's like three parts to my presentation today. So I think what I want to do is not overwhelm you, that we can kind of take it in three different pieces. So if you have questions, we can do that. So there we go. So I want to first describe the model, our patient-centered team-based care model. And with that, here I am. I'm looking at my slides already. I'm sorry, folks. Okay, so the model. We developed this patient-centered team-based care model as part of this grant award that we have, and it was, can patient-centered team-based care really help address the issue, some chronic disease conditions like hypertension, as well as diabetes. And in terms of this model, we believe that it demonstrates what is patient-centered team-based care and services, what are the influencing factors as we develop and provide team-based care services. We really believe that using patient-centered team-based care, you're going to find environments leading to very active and informed and engaged patients, which we all need these days. We also need to identify and acknowledge that as we look at population health, that connection and linkages to the community. So we're not working in silos, but rather really trying to make a difference in the health of our patients, that we need that connectedness. We want to, by what we produce, is to really increase that awareness. And the other thing we realize is the model just doesn't work for hypertension. It can work for many chronic diseases. So when we put forth this model, this is what we wanted to accomplish. That first of all, patient-centered team-based care is a healthcare transformation strategy. And thinking that given all that's out there and kind of pressuring our healthcare systems in terms of meeting the needs of our patients, taking care of our staff that are delivering the care, and those systems trying to deliver that, it is a transformation strategy. We provide an overview, and we've done a lot of evidence-based and a lot of literature review where we looked at the principles, the practices, the components, how this model can be applied, and the dynamics of a patient-centered model. More importantly is that this really is about interdisciplinary and interprofessional care. Again, we talked about the need for our connections beyond the walls of our institution. The bigger piece is, as we look at this model, that we want you to find that it's more about capturing the antecedent conditions that are needed to provide a team-based care approach. By having those antecedent conditions, we believe that organizations that are thinking about developing a team-based care model, that these are sort of the background or some of those important components and elements that you want to, and culture change that you want to have in place and thinking about as you develop your program. The second thing is for those organizations that have team-based care and are operationalizing it at this point, we're thinking that you could also use this as a benchmark to see where there might be some gaps in how we are providing the services. We have 3 core elements that we identified, and that being the team, the parent organization, and the interprofessional diverse workforce. We think having these antecedent conditions can really help support what is obviously needed is a very high-functioning team. Sorry. Sorry, folks. There we go. The very other last piece that we want to share in terms of as we develop this model is that we believe by accomplishing and having a very active, functioning team with a supporting organization, that we really can improve patient safety and healthcare outcomes. We also thought of, and we're kind of seeing now, that it can address some of the clinician dissatisfactions that we're hearing so much about. And that having that important dialogue about collaborative thinking and working and leadership can contribute to, again, better health outcomes. The operational definition that we identified, and this came through the wisdom of an interdisciplinary group of clinicians and educators and folks that are interested in this work put together. And what we identified, it was from Mitchell, as part of the IOM work, that team-based healthcare is the provision of health services to individuals, families, and or their communities by at least 2 health providers who work collaboratively with patients and their caregivers. They do this to the extent preferred by each patient, thus sort of having your patient-centered model. By doing this, we want to accomplish their shared goals and within and across the settings to achieve a coordinated, high-quality care. So I want to talk about the model. This is the schematic that we've developed. And when you look at it, we want you to see that it is indeed a relationship model where everything is interconnected. But the central focus of the model is the engaged patient. And I say engaged because we don't want a passive patient. We really do need them engaged to help really promote their health. That the model relies on leadership and connectivity between our three core elements. And as you can see, that's the team, it's the parent organization, and the interprofessional diversity of the workforce. We have the three influencing factors, because we know the triple aim for healthcare continues to be that huge goal that we're trying to achieve three major things, and now the quadruple care, four major things to take care and improve our health system through cost, through patient engagement, satisfaction, and access to care. And then surrounding all of that, and trying not to show that there's boundaries at all, but working with our communities that really trying to break through those institutional walls and opening up those doors within the community to help really improve our patients' health. And lastly, we want you to see that this model, we hope you'll see, expresses that the whole is greater than any individual element. I want to start with some of the major components of the model. First is the engaged patient. And obviously, they are the central focus of this model, and that the care is delivered and provided with an engaged patient. So there is that exchange of communication, education, teaching, understanding what the patient's needs are. The IOM described our goal in delivery of health care and how patients under team-based care can support this is that we want our patient to move from care to me, to care with me, and then to care by me. And it doesn't mean we let the patient do and use the internet for everything. They still become our chronic disease patients, do remain, part of this patient-centered team-based care model. But part of the role of the team is to really help that patient's confidence in taking care of themselves as they can and practicing self-care services that they can to help better their health and keep themselves as healthy as possible. We have three elements, and the first one we call the parent organization. And the parent organization obviously is that entity that provides the leadership and the infrastructure. It is what's needed is the culture of the parent organization needs to be reflected in the culture of the team. It's also about working with leaders, the parent organization being the leader, as well as working with the leaders within the team to really promote positive patient outcomes. We also believe that the parent organization is the first in creating those linkages with the communities. And by identifying and working together and building those relationships where we can help one another will continue to provide what that patient needs is trying to achieve those things that they need outside of the walls of even the primary care clinic. And lastly, and it is the parent organization has the control over the policies, the employees, the expenditures, the structures, and the services that it oversees. So we believe that that's probably starting with that organization, or with that part of the system first. The next is the actual team. We want to see that the team is functioning as a microsystem of the parent organization, that the team will own its own principles of team-based care, that it's the processes they develop or workflows and their actions become part of the team, that they're working on protocols as a team. They work together in evidence-based practices and trying to standardize the care as best as possible. And that it is the member of the team will have a relationship with that patient. There's the first contact all the way to, as again, if we think about chronic diseases, the other different disciplines that the patient will be working with, that is indeed part of our team. We talk about the interprofessional and diverse workforce, that when we view this, first of all, the team, it needs to work with a variety of interprofessionals or disciplines. And we'll learn a little bit later about how some of that looks in terms of the organizations that are designing or that are delivering patient-centered team-based care. But it really is about those folks being able to work together, that the team members want to learn together. They want to be as diverse as the demographics of the population that they're caring for, and that each team member is able and is supported to practice to the full extent of their education, training, and experience. So at this point, I'd like to open it up to see if there's any questions about the model. And while we're doing that, I want you to know that you can find out a lot more about this model by going to our website, where we have provided a lot more detail as well as the actual paper that describes it.
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to remove from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. Standing by for questions. And once again, if you have an audio question, please press star then 1.
And just a reminder too, folks, if you prefer to put questions in the Q&A section or the chat section, that's fine as well as we're moving along, and Gina can stop to answer those.
And I am showing no audio questions at this time.
Okay, thank you. So what I'll do is we'll move on to the second part of the presentation, where we now have this model in place, and this is where we began to have this conversation about hypertension. And does the model work for identifying hypertension and or treating hypertension? So a little bit of background. As I said, we had this, it's a chronic disease and prevention grant from the CDC that was awarded by our state of Wisconsin Department of Health Services through their Division of Public Health. So the focus of our work included creating a conceptual model of patient-centered team-based care, and then focusing on the pieces related to hypertension. And that's where we began to partner with Medistar because of the Million Hearts work and their whole emphasis on hypertension. And then lastly, how can we, by doing these together, create system transformation? We started with, in our meetings as a group, with the Department of Health Services to look at sort of what is this pathway we're trying to achieve in addressing and getting at hypertension, and where does team-based care fit? So the next slide shows the algorithm that the department developed, and what I want to do is kind of focus on the pieces that we had. Our goal as we began to look at getting treated, getting identified. So there were three conditions that we looked at related to hypertension. One was that we identify undiagnosed hypertension. Those are those folks we call hiding in plain sight. That we have the condition of a patient that is diagnosed but not in control. And then those are diagnosed and in control, which is there but not the emphasis of our model, other than to see what were practitioners doing to keep that patient in control. As we move down, you can see that the system strategies, which in this case is about patient-centered team-based care, and using that approach, that the systems adopting strategies regarding their policies and procedures, identifying models, and to control hypertension, and thinking about the patient-centered team-based care work. So that sort of gives you a picture of our pathway. We go back to the question of why are we looking at hypertension. What we found in terms of in 2015, the incidence of or prevalence of hypertension in Wisconsin, we found not any different than what we have found nationally, is that 30% of Wisconsin's population over the age of 18 and older have a diagnosis of hypertension. Moving down to the next boxes, we have 46% that are controlled, and unfortunately we have 54% that are not in control. So when we go back to the title, when we talk about beyond 50%, what we're trying to do is be able to get back to that 50% getting over to the control side and then some. So when we talk about uncontrolled hypertension, there's a lot that we need to do as a state and probably as a nation in really trying to address this condition, which is typically silent, but we also know the implications of not treating, and that's again what Million Hearts helps us with. When we saw this WNA in terms of our work and part of our relation to the grant, we identified or we've implemented 5 major activities. First of all, because of that 50% and over 50% not in control, we partnered with the American Medical Association, Department of Health Services here, and Medistar. We, based on the evidence that clinicians needed a refresher, based on the new research that came out of Johns Hopkins, a refresher on the better ways in measuring blood pressure. And when we have started to put this out to a variety of practitioners, they all appreciated the new approach and they understood the why. So that we have created an on-demand educational offering. The second thing that we'll be working on tomorrow, as a matter of fact, is we thought it would also be important to provide a webinar on how to position not only your patient to take and get an accurate blood pressure reading, but also how does the practitioner themselves either sit or respond and help try and lower that individual's blood pressure so it can be retaken. And then we have convened and will be reconvening a group of, what we call it, our clinical expert panel that understand both patient-centered team-based care as well as hypertension. And our goal is to look at the model, the components of the model, and then look at hypertension and what sort of strategies or recommendations can we put in place to really get at this issue. And this expert panel so far has looked at patients, the team members, and how they can address undiagnosed hypertension and uncontrolled, as well as the parent organization, what sort of role and responsibilities do they have in wanting to address this. So we've got some provisional data, information that I'll be sharing with you, but I want to talk to you about the other two pieces of our activity. So tomorrow, May 17th, we have this clinical expert panel reconvening, and what we want to do is we looked at their recommendations, and what we want to do is see how they align with Millions Hearts 2022, or they call version 2.0. And their 4 goals for this time being is now keeping people healthy, so applying team-based care approaches. How can we keep people healthy? How can we optimize care and improve outcomes for our priority populations? And, optimizing care and improving outcomes. So that's the three goals, We also are going to continue the work where we need the clinical expert panel of where can we identify some ideas about how can we better improve our linkages between the health system and the services that are available in our communities, or to identify and help get those services to our patients in the community. And the last thing I want to share is we did conduct an interview of 8 Wisconsin health systems to look at how far they have operationalized their team-based care and how have they implemented this in relation to hypertension and diabetes. So the first thing we did is, in terms of the expert panel, this is what I want to share with you, are the recommendations that they developed a couple months ago. And they looked at the parent organizations first and said, okay, so how can our parent organizations, what is their role and recommendations, role and responsibilities for addressing and helping address uncontrolled and undiagnosed hypertension in our communities. And the recommendations that have been developed, I've put it here in this slide, and I'm not going to do all this reading because I'll let you be able to do that on your own. But first of all, we need the parent organization to establish a culture of patient-centered team-based care for hypertension prevention and control. And some of those subcomponents that they looked at was that we need to invest in patient-centered team-based care as a delivery standard, and that we need to develop and support a culture that allows the team to actively measure blood pressure and provide interventions to patients at every appointment or every contact. They also very much talked about, because we have all these EHRs and these records, that can we begin to establish real-time registries where that data flows in terms of the reading that you might have of that individual, or past readings to see will they pop up in a registry in terms of who are those patients that might be hiding in plain sight. So the role of the parent organization to help get the dollars and the capacity to get that to happen. A second recommendation that the panel had, and again from the parent organization, is to establish a system-wide principle that all healthcare providers are involved in prevention, diagnosis, and treatment of hypertension. A lot of what we talked about were patients go to the specialist, healthcare specialist, and may have their blood pressure taken, but we want to make sure that the blood pressure is being accurate and that it's being reported. The other piece is improving that dashboard capacity for the electronic medical record to support efficiencies in care delivery and patient safety. And by that, they meant that some alerts could pop up about informational resources or guidelines for treatment, goals for control, and appropriate medications. And then lastly, establish a system-wide goal for hypertension. And again, that we do need the parent organization to sort of set that expectation in place. I would now like to move on to what the recommendations were for teams in addressing, first of all, the uncontrolled hypertension. That what they are recommending that we measure blood pressure accurately and appropriately on all visits. Whether that's what the patient is coming in for, that we're going to do the reading and it's going to be important regardless of any other reason that it gets recorded, and if it's beyond the parameters, expected parameters, that we're going to do something about it. That we need to improve communication within and among the team members. Also allowing team members to act to their full level of their license or education for those non-licensed teams. So part of what the conversation was about, allowing data entry into the medical record by all team members. And by that, if you have your medical assistant, it's the person that is part of the rooming process, that is taking that individual blood pressure, that they will have and be empowered enough to put that information into the record so the practitioner can see what it is for that day. As well as our receptionists and staff working together to say, let's get this person in, and to create a system of same day and accurate for appointments. Continuing on with the teams and addressing uncontrolled hypertension, that we want to establish clear roles for all team members to assure care coordination with linkages to community resources. And this is where, again, that with care coordination in between your visits, but at the same time making contacts with the other person is doing in terms of their goals and their activities of how they want to get that blood pressure down, but also who in the community can they have contact with to help support this. They talked about establishing an uncontrolled blood pressure team. So it becomes part of the huddle, maybe when they're looking at your patients with chronic diseases and those hypertensions, that there's a team that goes into place and kind of works on the processes or the protocols that they want to use. Obviously, collaborate with the parent organization on these, what we think we could use in our IT world in terms of what can best make us efficient and at the same time achieving good quality care with every visit. And then acknowledging and dissemination of team successes, shown to improve efficiencies and effectiveness of operations of patient care. And we know we all have our metrics that we need to achieve, part of reimbursement. So that sometimes just comes with a particular practitioner, but to share those outcomes and those measures with the team, I think can go a long way, either challenging themselves to want to do better or to really celebrate that what they're doing is a good model and a good practice. In terms of the teams, and these are our undiagnosed people, are hiding in plain sight with hypertension. So first of all, started with measuring the blood pressure accurately and appropriately at all visits. Again, letting team members, if they find that person's blood pressure is elevated, that they're going to use the system-wide process for when they're going to retake the blood pressure, and using the right methods and procedures to make sure that you can get, that you're going to retake it and that you're going to get hopefully a better reading. Again, that we're developing that rooming system that allows for blood pressure measurement. Also, they talked about establishing an undiagnosed blood pressure team, and that means, who's going to go into the registries and look at who are those patients that have been recorded as having a high blood pressure where no action has been taken, for example, and then what can the team do to help get that person re-evaluated and treated if necessary. Certainly, again, the relationship with our community-based providers and to support identification of reporting of patients with undiagnosed hypertension. I think a lot of our patients in the community will go to a variety of places to have their blood pressure taken. And in some cases it might be our pharmacies, in some cases it might be the public health department, but Taking it is important, and taking it properly is important, but how do we report it? And it's one thing to write it down on a card for our patient, but is there another way that we can maybe assist in getting that information to the patient's team member? So at this point, just to kind of summarize the section that we started with a pathway to help us understand the goal of our work and identifying how patient-centered or using a team-based care approach can help us attack or address the uncontrolled and the undiagnosed, and using team-based care and putting those strategies and those processes and organizational pieces in place, hoping we can better diagnose and treat. So at this point, I'm wondering if there's any questions.
And once again, if you do have an audio question, please press star, then 1. And I'm showing no audio questions at this time.
Okay, well that means I'm going to move on. So our next piece that I want to share with you is the interviews that we conducted with 8 different Wisconsin health systems. And these health systems were both rural and also located in metro areas of Wisconsin. And I want to begin to talk about, and again, we were asking about team-based care delivery, and as part of our conversation or interview, we talked about how is this working, or are they applying it to hypertension. So the purpose of the interview was to just kind of capture a point in time of where an organization may be in their delivering team-based care across Wisconsin. We developed a semi-structured interview guide with primarily open-ended questions. And I can tell you that the team or the folks that we interviewed were so excited to share their stories and their journey. The questions and topics is we had to get a sense of who is the health system and what is the role of the person that we're chatting with and their connection to a team. So we had a variety of individuals responding based on the health system that they were with. Again, asked about team-based care in general, and then we talked about, what is their specific team-based care implementation, what's been implemented, what's their strategy for continuation. And what we were able to capture within these interviews was how is it being delivered, why is it being delivered, do you think, in that way, to what extent are the health systems implementing and practicing team-based care, and then to be able to sort of capture what are the barriers or their challenges, what are their successes, who is the team member, who are the team members, and then what are some of those workflow and design pieces that you have put in place in regards to hypertension. So what I want to share with you is sort of the high-level overview of the HighLevel findings. There's a lot of details that are part of this report, but I just want to give you some of the themes that emerged. So in terms of the findings, we talked about what are your barriers and factors to what you're doing, the successes and the benefits, who are your team members, and then sort of what is that workflow and design. I'm going to start with the barriers and factors first. What they were finding as they were beginning to implement that, there was a lack of standardization and evidence-based protocols. So different clinics were adopting team-based care, but one clinic might be doing it this way, and another clinic might be doing it that way. So trying to work together as a larger team to identify how can we standardize and what are the evidence-based practices that we would want to implement. We also, the team culture, we'll be seeing how the parent organization's culture is it indeed being reflected in the team, and the care team relationships. This is sort of where that whole concept of silos, practicing in silos, were identified, and how were they beginning to break those silos down. What is both the capacity of staff and what kind of staff were in the clinics on a regular day, or what did they need? Really trying to demonstrate the value. And that was, other than the usual metrics that are collected in terms of performance measures, but we know that for insurance purposes, we need to gather a lot more information. We talk about the buy-in, and that was mostly by, first of all, the parent organization, the team, and then the team members, because they really were shifting their culture as an organization and as a particular unit. And then, the investment or financing of this new care delivery model, what was available for the parent organization to use to help support this change, and trying to figure out the best ways to do that. Next factors in terms of barriers, obviously, was the payment structure and reimbursement, which I think is obviously a federal piece of conversation that needs to take place as we demonstrate our value, as well as at the state level. What is the organizational structure? What does that look like? How is it being supported, and what does the team, or what are they seeing? What are the resources, other resources that were needed? Communication, trying to improve that between and among the team members, also maybe clinics to clinics, as well as clinics to the parent organization. The physical layout, some changes were identified and thought was necessary to improve the effectiveness of care. And then just some of those other things were the patients themselves, the goal setting with patients, and again, the kinds of metrics that we need to show more than just in terms of our patient outcomes, more than that. The successes and benefits, this is where the interviewees just really love talking about. They found that the staff and team satisfaction was greatly improved, so that everyone was considered an equal partner in the team. And with that came the satisfaction. That we found the patient outcomes and the quality metrics in relation to hypertension had improved. That patient care satisfaction and the access of the patients having access, very much a satisfier. Communication was necessary between the team members. Also trying to anticipate that patient visit for their encounters, so trying to get those screenings and laboratory work done ahead of time so that you had a meaningful visit. The whole top of licensed practice, and sort of like what we were saying with our medical assistants being able to effectively, and doing it right with in-servicing on taking that important blood pressure, allowing, what that has produced is allowing that practitioner to do the work of a practitioner and working to their level of education and their level of critical thinking, and having more meaningful time with their patients, being able to educate and teach and talk. Certainly interprofessional collaboration, the whole advancements in relation to our EHR systems, and that they really did come up with some great ideas about standardizing the rooming process. We then took a look at So who are the team members? And we took, there were 4 different categories, but every site utilized a pharmacist, a physician assistant, and a social worker. And then most sites had an administrative leader or administrative and support staff. They had a care coordinator. For the patients with diabetes, obviously, they had a CDE. There were DOs, there were LPNs, certainly the MAs, our nurse practitioners, the pharm techs, utilizing that registered dietitian or nutritionist, as well as the registered nurse. It does take a village, doesn't it? And when we looked at workflow and design and the interviews related to what are some of those workflows and designs that you have, a consistent theme was using work groups. And by that, work groups to look at the flow, can we make it better? Work groups to help look at some of the better protocols or implementing and researching some practices that they might want to implement. Creating protocols and standards of care that, again, all agreed on by the team. The need for the support tools and the EHRs to really be able to capture the information about that patient in real time. The team compositions and the dynamics of the team. How do we get them to all think as one unit? Pre-visit planning, and that took place through huddles. And they're also, with the patients with the chronic disease, having time either in the morning or during the day to talk about, to huddle about the patient population. Maybe the ones with hypertension will be the focus. Certainly, interaction with that patient and how we move them from maybe the practitioner to maybe the social worker. Or from the practitioner to the care coordinator, all those sorts of things. So it's a workflow that patients understand and appreciate. And lastly, transparency. So the next steps in our the interview is we have recorded the presentation or the report, and our goal is to have that on our website as a webinar, and that launch date is June 30th. And I think you'll find the information at a much greater level of detail that I think you'll find very interesting and very helpful to your practice. So at this point, wondering if there's any specific questions related to our interview work.
And once again, if you do have a question, that is star then 1. And I am showing no audio questions at this time.
All right. Well, I'm going to just finish up then. And again, thank you for your time. And hopefully this information was of interest and hopefully helpful to you. And I just want to, again, if you want to go to our website, you can go to wisconsonnurses.org and find the information about patient-centered team-based care, TBC, and you'll find information about some conferences that have taken place in Wisconsin related to team-based care. We have a summary of the findings that the different presenters put on. We also have, again, greater detail of the model and actually the conceptual paper. And you can also find the on-demand webinar for taking blood pressure is on another section of our website, and it has to do with education. So, again, thank you for your time and interest. We're feeling pretty good about our progress and look forward to our continuing work with the team members as well as with Metastar for sure. Thank you.
Well, and right back at you, Gina, and thank you so much for your presentation today. And again, I encourage everyone to check out those resources on the WNA website. And it sounds like we'll have some good stuff coming out here at the end of June as well. So again, if there are not any questions now, you can see Gina's contact information. And again, I'm Ashley Green at Metastar, so feel free to contact me as well. And if that is it, we will go ahead and bid adieu to everyone, and thank you for your time. And thanks one more time, Gina. Really appreciate it.
Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.